Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. The webinar is being presented by the Division of Blood Disorders and Public Health Genomics at the U.S. Centers for Disease Control and Prevention, CDC. I'm Alejandra Gutierrez Bernal, and I'm delighted to serve today as your moderator. I'm an assistant professor in cardiovascular critical care at the University of Minnesota, and I'm the cardiology lead for the pulmonary embolism response team at my institution. It's my pleasure to introduce our wonderful presenters today, Dr. Michael Knox and Dr. Carin Gonsalves. Presenting first will be Dr. Michael Knox, who's an interventional radiologist and co-chair of the pulmonary embolism response team at Corewell Health in Grand Rapids, Michigan. Dr. Knox, along with the team of providers at Corewell Health, have developed a successful VTE program at their practice to better treat VTE patients and improve their outcomes. He will be followed by Dr. Carin Gonsalves, who is a professor of radiology and the co-director of the Division of Interventional Radiology at Thomas Jefferson University. She's also the co-founder and co-director of the Pulmonary Embolism Response Team at the university. Dr. Knox and Dr. Gonsalves will be sharing more about the use of mechanical thrombectomy for venous thromboembolism. So before we begin, a couple of housekeeping things for everyone joining the webinar. So the webinar will be approximately about an hour, and the webinar is being recorded. The audio will be muted. At the end of the presentation, we will have time for questions. To submit a written question, please use the questions area of your toolbar, and we'll respond to as many questions as we can. We will begin with two brief audience polls because we want to know more about you and kind of tailor our presentations to that. Please select your response to the poll questions now. Which of the following best describes you? Please select one of these: healthcare provider, public health professional, person with VTE or PE or a family member, community-based organization, or an industry partner. Okay, so we have about 40% healthcare providers, and then industry partners about 25%, and the rest is mattering of the rest. Thank you so much for that. We have one more poll for you. What region of the world are you from? Please select one of these again: North America, South America, Europe or Russia, Asia or Africa, Australia or New Zealand. Okay, so the majority of our audience is from North America, kind of not surprisingly. So we will get started with a very brief introduction and then right into the meat of the topic of the talk, which is our wonderful presentations. Our learning objectives are here. Basically, we want to understand the role of mechanical thrombectomy to know how it's transforming VTE treatment. We want to understand when we should use mechanical thrombectomy and when we shouldn't, and kind of describe the recent scientific developments and how the advances are kind of changing the future direction of VTE treatments. As an introduction, VTE, referring to DVT and pulmonary embolism, causes a lot of morbidity and mortality. Actually, among cardiovascular disease, PE is the third most common cause of death, and it affects 900,000 people a year in the US, leading to 100,000 deaths a year. The incidence of VTE is growing, and this may be because we diagnose it better, because the age of our population is increasing, the weight of our patients are increasing, and then we have more patients being hospitalized. And there's more therapies in the horizon that include the systemic fibrinolytics, catheter-directed lytics, mechanical thrombectomy, that have all been studied and developed, and we'll learn more about the evidence behind them. So a little bit about mechanical thrombectomy. It's a catheter-based technology that will enable to remove or break up that blood clot, but it has some significant challenges, and basically we'll talk more about it today, but we don't have a standardized patient selection for these patients. It requires competency and can be complex. Sometimes it's inefficient in clot clearance, and then it can lead to blood loss. We many times need large bore, and we can have some bleeding. And we'll talk about the data behind it, but most of the data has been based on surrogate markers used in trials. So with that, I'll turn it over to Dr. Knox to start talking about DVT.
Okay. So welcome everybody, and thank you to the CDC and NBCA for asking me to share some thoughts about use of mechanical thrombectomy tools for the treatment of deep venous thrombosis. Let's see if we can advance slides here. It's going slowly. Despite the practice run that worked, it's not. Oh, there we go. So we might ask the question, why would we consider treatment of DVT with catheter-based intervention as opposed to just simple anticoagulation? I think we have to look at several factors. One, is it of value to restore patency of veins early on? And so it's called open vein hypothesis that's been bandied around for years. The other factor in deep veins is the valvular function, and if we can preserve valvular function, does that improve long-term outcomes in terms of venous reflux and potential sequelae of DVT? Prevention of pulmonary embolism, because that's where the vast majority of PEs originate, is from DVT in the legs. And most important, I think, is to limit the recurrence of DVT in the lower extremities and hopefully prevent the post-thrombotic syndrome. So if you look at the overall incidence of recurrent DVT and PTS or post-thrombotic syndrome in these patients, is not trivial over time. In fact, PTS may occur in up to 50% in some studies in patients that have had an episode of DVT. Overall survival is somewhat tied to DVT as well. And if we look at those patients that have residual venous obstruction from DVT, there's certainly studies that demonstrated increased risk of dying from all-cause mortality, recurrence of VTE, development of the post-thrombotic syndrome, and if patients require stenting to improve the outflow from their lower extremities, it's the highest or the most powerful predictor of venous stent failure if there's residual thrombus in the leg below. So we look back at the history of how we got to where we are today. It's interesting because Charlie Dotter in the 60s was the first one to perform a catheter-directed thrombolytic procedure. It was in the arterial bed in the superficial femoral artery using streptokinase for acute arterial thrombosis. But it wasn't really until a couple of decades later that the group at Stanford, Simba and Dake, presented their series of using catheter-directed lytic therapy for lower extremity DVT, and they were using urokinase at the time. Jump forward another couple of decades, and the Surgeon General issued a call to action for focus on venous thromboembolic disease. So since that time, I think there's been a really renewed interest in terms of how can we treat these patients optimally, and what tools can be developed to improve treatment efficacy and outcomes. In 2014, ECOS developed a way to potentially improve upon thrombolytic administration, and that's with an ultrasound facilitated catheter that helps disseminate the thrombolytic agent into the clot. And then in 2018, another milestone, Inari Medical developed a device, ClotTriever, that uses a mechanical coring element to remove clot and capture it in a basket and physically remove from the body. They also released an aspiration, catheter large bore aspiration system called FlowTriever. And currently there are several other devices on the market available for doing mechanical thrombectomy, and there are many that are in development. So we expect to see quite a few new tools coming on board to allow us to choose what may be best for any specific situation. Looking back at Dr. Dotter from Oregon, he proposed a logo for his work, which is really a plumber logo, and that's kind of how he envisioned a lot of the work that he did is restoring patency to pipes. But he wasn't necessarily embraced in at that time. And in fact, a famous requisition from a surgeon to Dr. Dotter to study lower extremity with the instructions to visualize, but do not try to fix. And I think that there certainly was not universal acceptance to those techniques. And it's taken many years to really become more mainstream. But even today, I think we'll see as we look at some of the studies and questions remain, it's not widely, there's not a wide consensus about how to treat these patients. In looking at the evolution of vascular care, we can kind of look back at how the treatment of myocardial infarction and stroke has evolved over the years, transitioning from thrombolytic strategies to more mechanical strategies with coronaries with balloon angioplasty, with stenting, with aspirational thrombectomy and other tools. Likewise in stroke, when our only tools were systemic thrombolytic drug infusions, evolved to catheter-directed thrombolytics, and now the vast majority of stroke work is done with mechanical tools to either physically remove with a stent retriever or aspirational devices. We're kind of going through some of that same transition in the treatment of venous thromboembolic disease, both in DVT and PE, and the tools are being developed that really make this technically feasible to achieve. And currently there are quite a few tools that are out there that the interventional radiologists or proceduralists that are dealing with PE and DVT have at their disposal. And so to kind of just briefly address some of these, the clot retriever device that we alluded to has a coring element on the front end, a basket to capture clot, and physically removes clot. But there's several aspiration systems, AngioVac, Penumbra aspiration system, and then there are other tools that involve some use of thrombolytic in conjunction with mechanical means, like a cleaner system that fragments clot and then allows aspiration, the rheolytic mechanisms which jet saline into the clot to fragment and break up clots and then allow aspiration, such as AngioJet and JetI, and then the ecosystem, which is the ultrasound facilitated thrombolytic therapy. But there may be real reasons to consider transitioning from thrombolytic therapy to mechanical strategies. And one important consideration is, does the patient have a absolute or relative contraindication of thrombolytic therapy? And in some series, patients with DVT and PE may have up to a 40% incidence of contraindications, so that that you would take any sort of advanced therapy for their disease off the table if you didn't have another strategy. The other significant factor is clot is not a static structure. It starts as a fibrin-rich thrombus that transitions over time to more collagen-rich structure. And so the thrombolytic agents we have, and they're typically used in alteplase these days, is a fibrinolytic, so it works on fibrin. And early on, the predominance of a clot is fibrin-rich and will respond to thrombolytic therapy. But after 21 days, about 80% of that is already converted to collagen, with a minority being fibrin, and the collagen does not respond to lytic therapy, so may be ineffective if we try to simply treat with thrombolytic therapy. Lytics are somewhat expensive too, in terms of just the overall cost of the drug, which for single session low dose therapy may not be a huge consideration, but in DVT specifically, it may be a multi-day infusion that requires several vials of alteplase. And the stability of the drug over time is limited, so that what our current institution guidelines are is a 6-hour infusion. At the end of that time, we have to open a new vial and create a new drip. And so can go through a lot of vials of alteplase and run up the cost pretty significantly if there's a multi-day infusion. The other factor is the duration of infusion, because thrombolytic therapy takes time to work and to dissolve clot. And in fact, if we look at the ATTRACT trial, the overall length of stay was a little over 6 days, but the infusion times are typically 2 to 3 days, for some of these more resistant clots, and may require adjunctive mechanical strategies as well. Whereas this mechanical means may be able, for the most part, to be done in single session treatment and markedly decrease the length of stay and potentially decrease procedure time to a single session of treatment. So how do these patients present? Well, we all know most DVT patients will have some leg pain and swelling. They maybe have discoloration of the tissues, feeling of heaviness or fatigue, pain with ambulation, and in worst case scenario, phlegmasia, where they actually may have arterial insufficiency from the severity of their DVT. The typical imaging workup involves venous Dopplers as a first step with color flow imaging, compression imaging, and then if it appears that the clot is more central, extending up into the iliac system, at our institution, we typically do CT to evaluate the abdomen and pelvis for central extension of clot up into the iliac veins or vena cava. Some places MRV is used. We don't use that so much, but it's certainly a good tool if we want to avoid radiation for whatever reason. It's just not typically as readily available as CT. The mainstay of therapy for DVT is obviously anticoagulation. And in those patients that for whatever reason can't be anticoagulated because of a contraindication, those are the patients that we consider inferior vena cava filter placement for. But there certainly is a segment of the DVT population that I feel, and most feel, we should consider advanced therapy. And although there is clearly some controversy around which patients should be treated, I think there's general consensus that if the clot extends up above the inguinal ligament into the iliac vein or inferior vena cava, we ought to seriously consider risk versus benefit and offering advanced treatment options. The other patient population that we sometimes see are those that may have infrainguinal disease in the femoral popliteal segments, but may be severely symptomatic. And it raises the question, is there involvement of more than just the femoral vein and popliteal vein? Is the deep femoral vein involved? Is the greater saphenous vein involved? And I think many ultrasound protocols don't routinely look at those venous systems when they're doing a deep venous analysis. And that's something over the last year or so that we have had our ultrasound techs and ultrasound readers do routinely when there's DVT extending up into the femoral vein, to look also at these other systems, because that may impact decision management. We developed a pathway that kind of gives our clinicians guidelines of when to consult for potential advanced therapies, and basically dividing the patient populations into proximal versus distal, and further subdividing the proximal DVT. Does it go up into the iliac vein? Is it limited to the femoral popliteal? And our personal feeling is that if it involves above the inguinal ligament up into the iliac vein, that all of these deserve at least consultation for consideration of therapy. Not that necessarily everyone needs to be treated, depending on all the clinical factors, but certainly at least evaluated for it. And many of those with femoral popliteal DVT that's isolated to the infrainguinal segments probably deserve evaluation by an expert as well, because there may be some other factors that play into decision to treat or not treat. Here's one of early cases after we adopted using mechanical thrombectomy techniques that really kind of points to some of the considerations. And this is a 14-year-old young man who is very athletic, hockey player, never had any significant illnesses, no DVT history or known genetic coagulation defects, but presented with a couple of day history of shortness of breath and left leg pain and swelling. And on CT, is not the greatest contrast phase looking at the pulmonary arteries, but there's a clot in the right lower lobe pulmonary artery, relatively small volume clot. There wasn't a lot of clot in other segments of his pulmonary arterial tree, certainly not central clot, no signs of RV strain, but he did have significant DVT in this left lower extremity involving both the femoral vein, the deep femoral vein, common femoral vein, and as our techs scan on up into the pelvis to see as high as they can, you can see occlusive thrombus extending up into the left iliac vein. So as part of his workup for PE, as a standard in our children's hospital, they all get echoes. And so with his echocardiogram, found a patent for foramen ovale. His right ventricular size was normal. His RV function was normal. All his biomarkers for PE were normal, but it was felt important to close his PFO because we were looking at doing a venous intervention for the significant left lower extremity DVT. And so that was closed with an Amplatzer, and he was sent immediately from the cath lab to IR for consideration of thrombolysis, which at the time was our predominant way of treating DVT. And it was something that the pediatric hematologist felt very comfortable with because of the experience over time. And so that's what we were asked to do. And from the right femoral vein approach, which is what the sheath was left in by the cardiologist, went up and over the bifurcation. You can see the left iliac vein showing extensive filling defects throughout the common iliac vein, external iliac vein, and in fact, all the way down the femoral vein. As it turns out, it was a little bit challenging getting the catheter all the way down, and so made the decision to treat like we do most DVTs, which is to access the popliteal vein. So the image on the right shows the patient right, left, reverse because he's prone at this point. A transpopliteal catheter in to infuse TPA with the ecosystem, the ultrasound facilitated system, which was instituted, and he received overnight infusion for a total of 24 hours of infusion of TPA, total dose of 24 milligrams. And the image in the top left here is after 24 hours infusion. You can still see significant filling defects in the femoral vein. And I don't have a cine of this, but flow was quite sluggish and not good washout. So there's still enough residual clot that we could not walk away at this point. And so the decision that we were considering was, okay, do we infuse another 24 hours of TPA, or do we do something different? And at this point, we had just gained early experience with ClotTriever, which is the device that has that coring element and basket, which we thought was important if we were going to do mechanical because of the PFO, even though it was closed. And so the image here to the right is after using the ClotTriever with 4 passes, rotating the coring element through all 4 quadrants, and you can see all the clot that came out after those 4 passes, which was left behind after 24 hours of thrombolytic infusion. Some of this, you probably can tell, is more tan in appearance, more chronic looking, some much more acute. But again, this young man, no history whatsoever, and it points to the fact that when we physically started removing clot with this technique, we realized how much of this is really chronic and how much may not respond to thrombolytic therapy. The outflow veins we studied, he has a bit of a May-Thurner look here, but not hemodynamically significant on direct catheter measurements or intravascular ultrasound, no collateral, so we elected not to stent at that point. And his 4-month ultrasound follow-up showed good patency of the iliac vein. I don't have an image, but all the way up into the iliac vein, widely patent, good flow, normal phasicity, and so he did not require a stent. Another case that's a little more dramatic example of the value of mechanical thrombectomy, and this is a 64-year-old lady who had an episode of DVT and PE in 2009. At a time she also had a GI bleed. Could not be anticoagulated. An inferior vena cava filter was placed at that time, and we follow all these patients very closely to remove filters when it's appropriate. And this patient, GI bleed resolved, went on anticoagulation, and so was returned at 4 months for filter removal, which turned out to be unsuccessful due to tilting of the filter. The superior aspect was embedded in the wall of the vena cava, and despite multiple attempts, could not be retrieved. And this again was in 2009. Kind of prior to some of the more advanced techniques for IVC filter replacement in these complex situations. So basically, walked away and said, you just need to stay on anticoagulation for a duration of, which was 6 months in this patient, and came off anticoagulation at that point with presumed permanent filter. She returns 14 years later with chest pain, abdominal pain, and hypotension and leukocytosis. Her CT here shows a pulmonary embolism on the right, relatively small volume in the big picture, normal troponin, BNP, but had some very concerning lab values otherwise. Her lactate was 5.2, markedly elevated. She was acidotic and had evidence of end organ hypoperfusion with abnormal liver function tests and renal function tests. And as the scan okay. As the scan goes down lower, you can see thrombus in the vena cava around the superior aspect of the filter and actually extending above the filter, and then in through the filter and extending down into both common iliac veins. So what the appearance of her legs also kind of drove decision making at this point: swollen, painful, and obviously discolored phlegmasia. So this lady is in trouble, from a perfusion standpoint, but even more so, end organ hypoperfusion from presumed. All this is due to acute iliocabal thrombosis with severely decreased preload to return to the heart and hypoperfusion. And so decision was made that something needs to be done now, and don't really have time for lytic therapy to work. So on the left here, you see her right common femoral vein, which is distended, largely filled with clot, a little bit of internal flow, but basically thrombosed acutely. This left femoral vein, smaller in caliber and has echoes within it, but on real-time imaging and compression imaging, this was compressible. So this is just severe stagnation of flow without actual thrombosis in her common femoral vein. So decision was made to access both her femoral veins and work from there. The anesthesiologist that was helping thought it was not a great idea to turn her prone and try to work from the popliteals. And really the mission was to clear her iliocabal system. So that is what is done. Here's showing access on the right, but basically got access to both femoral veins, access to the internal jugular, all with her supine, able to come down from the jugular approach, see the clot extending above the filter into the suprarenal cava, a lot of thrombus occlusive here in the juxtarenal cava and inferior to the renal veins. So with access to the left femoral system, you can see the external iliac vein is wide open, but the common iliac is completely occluded, and also a lot of thrombus in the right iliac system. And here is a large caliber flow retriever device down into the vena cava after working on the filter area, and I'll show you that in a minute, but capture wires from both groins, so we have through and through access bilaterally, and that gives us some options in terms of how best to clear the iliocabal system. So with those multiple points of access, we can do aspiration, large bore aspiration thrombectomy from the right internal jugular venous approach, from the right femoral approach. These are 20 French aspiration catheters to suction thrombus. You can also run that clot retriever device with a basket, protecting the filter with this superior sheath, but to clear both iliac systems using clot retriever. And at the end of all this, basically cleared the clot above the filter, through the filter in both iliac veins, and extensive amount of thrombus removed, much of which is very acute, but a lot of which is very organized and chronic as well. Again, the chronic stuff likely not amenable to lytic therapy, and in this particular patient, the time was not there to allow us to even try lytics. So how do we make decisions based on the existing literature? And I think that the ATTRACT trial certainly is the largest randomized controlled trial, very robust and well-designed study, sponsored by the NIH, looked at 692 patients at 56 different centers that received catheter-directed thrombolytic therapy versus anticoagulation alone, and followed them out to 2 years to see outcomes. And basically the conclusion of the study was that there was no significant decrease in the incidence of post-thrombotic syndrome or quality of life between the two populations, but a lot of subgroup analysis has been done, and there's still many questions left at the end of this study. And so when you separate out the iliofemorals from the femoral popliteal, DVT patients, there does appear to be a trend toward significant improvement in outcomes with a catheter-directed strategy as opposed to anticoagulation alone. The other thing in the entire population, the incidence of severe PTS was slightly decreased as compared to more moderate, even though the overall incidence was equivalent, and the time to improvement of symptoms in these patients that had acutely painful legs was shorter in the treatment arm. There are a couple of other trials that are randomized between catheter-directed thrombolytics and anticoagulation. Both the CAVIT trial and the CAVA trial showed slightly improved lower incidence of post-thrombotic syndrome in their treatment arm. So I think there's still some questions out there in terms of which patient population might respond best, which is appropriate to consider catheter-directed therapies. The other couple of interesting things about ATTRACT is that the overall incidence of venous reflux on these follow-up studies was equivalent between the two arms. So, and it was high. It was like in the 90% range. So a lot of these patients develop long-term sequelae of their DVT. So that's another factor that at some point we need to pay attention to. The Clot trial, which is the Inari-sponsored trial using Clot treater, is a registry basically, but 500 patients treated at 43 different sites and 2-year follow-up as well in terms of clinical outcomes and ultrasound imaging. But a very real-world analysis of use of mechanical thrombectomy in patients with iliofemoral DVT. And why is that not advancing? Okay, oh, geez. So here are some highlights of that study. First of all, safety. You know, is it safe to put in a large caliber device? And this is a 13 French sheath that goes in the popliteal vein, and so device-related adverse events, very low incidence. Almost all were treated in single session as opposed to multi-day infusion of thrombolytic therapy. Blood loss minimal, and no documented case of valve damage or vascular injury by using this mechanical device. And interestingly, when you look at the clot that's removed in this patient population, about a third appears fairly acute, but a third is subacute in appearance, and a third is very chronic in appearance. So again, it's kind of a mixed bag and what you might expect to see in DVT, and you don't know when you go in to treat these patients what you're dealing with. Good news is with this mechanical treatment, over 90% had complete or near complete clot removal. How did this study show the post-thrombotic syndrome rates compared to other trials? And is very favorable. The overall incidence at 2 years was 7.3% compared to around 20% with both arms of the ATTRACT trial as well as both arms of the CAVA trial. So I think that there are no head-to-head trials to show mechanical thrombectomy versus thrombolytic therapy, but it's suggestive that there may be a benefit to mechanical treatment of DVT. There are some randomized controlled trials that are in the works, and hopefully will provide some more information for us in regards to this. The Defiance trial, another clot treater trial, but randomized to mechanical thrombectomy versus anticoagulation alone. They're looking at enrolling 300 patients with symptomatic iliofemoral deep venous thrombosis and following over a couple of years. Penumbra is doing the Bolt trial, similar using their system of aspiration thrombectomy versus anticoagulation alone. And then another interesting component of treatment in DVT overall is what do you do with outflow obstructions and restrictive lesions in the iliac vein? Is stenting appropriate? Who to stent? What degree of stenosis makes sense to consider stenting? And so the C-TRACT trial, another NIH-funded trial that will be randomized to stenting versus no stenting for venous occlusive disease, to hopefully shed some light on the role and the appropriateness of stenting. So I think we have a lot to learn going forward, but it's very encouraging that mechanical thrombectomy offers promise for prevention of post-thrombotic syndrome and treating these patients effectively. Many companies are working on devices and improving devices all the time so that tools will get better. There's no question that we'll have better tools going forward to treat this disease. We definitely need long-term clinical outcome studies that robustly look at not only anatomically what the veins look like, how they have done with each type of intervention, but how the patients have done clinically, and quality of life and performance criteria, I think, are going to be very important to evaluate. The other topic that is not a topic for today, but it is certainly related, is chronic DVT and management of patients that have already developed a post-thrombotic syndrome. And the good news is there are many tools in development to address this, with dedicated venous stents, with devices to help opening chronically occluded veins or stenotic veins. So I think that there's real promise on the horizon of being able to help those that already have developed signs and symptoms of chronic DVT. So I will turn it over to Carin here.
Good afternoon, everybody, and thank you again to the CDC and the National Blood Clot Alliance for giving me this opportunity to talk about suction thrombectomy for the treatment of acute PE. So I'm going to begin with risk stratification for acute PE. And as you all know, PE presentation is quite variable. It ranges from asymptomatic to cardiogenic shock and sudden death. So risk stratification models have been created to help guide appropriate patient management. And the two most commonly used models include the American Heart Association and the European Society of Cardiology guidelines. And both of these models focus on the right ventricular's ability to handle an acute increase in afterload. Because the primary cause of death from PE is RV failure, leading to hemodynamic collapse, and sometimes this is referred to as the spiral of death. So this is just to emphasize that point. On the left-hand side of the screen is a graph from the iCopper study published back in 1999, which shows that RV dysfunction doubles mortality rate in the ensuing 3 months post-PE. And on the right-hand side of this slide shows a graph that looks at elevated troponin levels, and elevated troponin levels are indicative of right heart strain. And this study showed that elevated troponin levels associated with a 4.5-fold increased risk of fatal PE. So how do we diagnose right ventricular strain or dysfunction? Well, typically either CTA or echo, and on the left-hand side is the CTA, which shows a right ventricular to left ventricular ratio of greater than 0.9. So this is one of the findings that you can look for on CT. The other thing you can look at is the interventricular septum is bowed to the left ventricle, which is also indicative of right heart strain. And what I'm not showing on this particular slide is that you can also have reflux down the IVC, which is also indicative of right heart strain. And just to point out, the RV-LV ratio is the most common surrogate clinical marker that has been used to assess efficacy of treatment in previously published prospective clinical trials and registries, and I'll get to that in a moment. And then on echo, there are various parameters that can be looked at to diagnose right ventricular strain, but McConnell sign, of course, is the most common one, which is right free wall akinesis with sparing of the apex of the heart. So the American Heart Association classifies PE into 3 categories: massive, submassive, and low-risk PE. Now, low-risk PE have normal blood pressure, right heart function, and have an excellent prognosis with anticoagulation alone. However, massive PE patients present with hemodynamic instability, respiratory failure, and without aggressive care, mortality could be as high as 65%. Whereas the submassive group, patients present with hemodynamic stability, but they do have signs of right heart dysfunction or strain, and they have about a 2 to 3% mortality. About 5% of these patients can decompensate into that massive PE category, of which we're not quite certain who those patients will be. Now, the European Society of Cardiology guidelines, which came out in 2019, so that's kind of a very important date just to keep in your mind as we go forward in this lecture, they divided PE into 3 classifications, high, intermediate, and low risk PE, with the intermediate category being subdivided into intermediate high and intermediate low risk PE. The indicators of risk included hemodynamic instability, that RV dysfunction, as well as that elevated cardiac troponin levels. In addition, these guidelines take into account clinical parameters of PE severity and other comorbidities by using the PESI, or the simplified PESI score, which I will remind you of. So these are the demographic and clinical parameters used to assess prognosis. The original PESI score is here in the middle, and then the simplified PESI on the right-hand side of the screen, and these are the different parameters that are evaluated. I typically use the simplified version because it's simpler, but if a patient has at least 1 point or more, you can see here it increases the 30-day mortality risk to 11% from 1% if the patient has 0 points. So just a word of caution though. Whoops. Sorry. So there are limitations of these risk stratification models because they only modestly predict short-term mortality. And remember, PE exists on a continuum of severity, evolve in real time, which is quite important, and are impacted by patient comorbidity. So it's really important that we do not use these models to replace a comprehensive clinical assessment of the patient at multiple time points throughout the patient's hospital admission. So let's go on to current treatment guidelines based on these risk stratification models. And if we look at the 2019 European Society of Cardiology guidelines, their recommendation for treatment of high risk or massive PE patients is systemic thrombolytics. Surgical embolectomy can be utilized if systemic thrombolysis fails or patients have contraindications to systemic thrombolysis. And then percutaneous catheter-directed treatment, which I'll talk about in a moment, their recommendation in these guidelines should be considered for patients with high-risk PE when thrombolytics is contraindicated or failed. Now, the reason why percutaneous catheter-directed therapy was not more heavily recommended during the time that these guidelines were created is because there was a paucity of robust data out there to really support the use of these devices. So just turning to intermediate risk PE patient, so these patients are the ones that are hemodynamically stable. The guidelines basically state that anticoagulation is the standard of care, and that remains the standard of care today. However, if somebody decompensates on anticoagulation alone, rescue thrombolytics can be utilized, or surgical embolectomy, or even percutaneous catheter-directed treatment. However, the one thing that has not changed or may not change is that the primary use of systemic thrombolysis is not recommended for patients who do not have high risk or massive PE. And the reason for that is based on the PYTHO trial, which was published back in 2014. It's a very large randomized controlled trial that compared patients treated with thrombolytics or anticoagulation alone when they had intermediate high risk PE. And what they found was that death and clinical deterioration was reduced by 56% for those who received thrombolytic therapy. However, the benefit of thrombolytics was counterbalanced by a 5-fold increase in major bleeding complications and a 10-fold increase in hemorrhagic stroke. So the authors concluded that great caution is warranted when considering thrombolytics for patients with intermediate high risk PE. So let's move on to the catheter-directed interventions, and are we transforming our current treatment algorithms because of these devices? Well, I'm just going to briefly mention catheter-directed thrombolysis devices. I just wanted to mention the 2 that have been FDA cleared for the use in the pulmonary vasculature, and this includes the Brashear Thrombolex device, or the Brashear basket, infusion basket, and then also the ultrasound-assisted catheter-directed thrombolysis catheter, better known as the ECOS device. And both of these devices allow intraclot infusion of thrombolytics, and this allows you to use lower TPA doses than what would be normally used for systemic thrombolysis. In addition, because of that, there's lower risk of hemorrhagic complications. And I just wanted to put together this table for you. You could take a snapshot of it if you'd like, but these are the trials, the prospective trials and registries that have been published over the last decade using catheter-directed thrombolysis to treat mostly intermediate PE. There are a couple of randomized controlled trials here. They're the ones with the stars, but these are very small trials, which it's very hard to draw any firm conclusions because of the size of the trials. But the primary outcomes, as I mentioned before, was really that RV-LV ratio, which is a surrogate for, as you know, a surrogate clinical marker. And they did meet their primary outcomes. And you can see that the bleeding complications, intracranial hemorrhage, and death were relatively low, with probably the exception of the Seattle 2 trial, which had a 10% incidence of major bleeding complications. But as Dr. Knox already mentioned, thrombolytics is not for everyone. So there are absolute and relative contraindications, not only for systemic thrombolysis, but also for catheter-directed thrombolysis. And you can see the list here. So suction thrombectomy devices, have become quite popular for a variety of reasons, which I'll get into in a second as well. But I just wanted to point out the two devices that have achieved FDA clearance for the use in the pulmonary vasculature. And the one on the left here is the Penumbra Indigo aspiration system. And then on the right-hand side is the Inari medical FlowTriever device. And the nice thing about both of these devices, of course, is that thrombolytics are not necessary for treatment. So in 2023, so about 4 years after the publication of the European Society of Cardiology guidelines, the FLAME study, which stands for FlowTriever for acute massive PE, was published. And this was a prospective, multi-center, non-randomized observational trial using parallel registries. So one group of patients was treated with suction thrombectomy using the FlowTriever device, and the other group of patients received either systemic thrombolysis or anticoagulation alone, and that this group of patients was referred to as the context arm. And in-house all-cause mortality for those who received the FlowTriever was about 2%, whereas those in the context arm was nearly 30%. And the study here, was actually terminated early because the authors felt that they had enough evidence to prove to use this as in suction thrombectomy for the treatment of massive PE, and to actually incorporate them into our standardized pathways. So just a case presentation here, and I just want to point out that PE does not discriminate. It doesn't matter what age, gender, race, ethnicity you are, whether you're the President of the United States or Serena Williams, which is one of my favorite tennis players of all time. PE, you can be subject to a PE. Now, this is just a case in point. This is a 23-year-old woman, a former college lacrosse player. She was status post ankle surgery, and she developed sudden shortness of breath, chest tightness, and lightheadedness. If you look at her vital signs here, she's tachycardic. Her blood pressure was low at 87/66. It did not respond to a small fluid bolus. She was tachypnic. She could not complete full sentences when speaking with her. Her O2 sat was 89%. And really just looking at it, although she was classified as a massive or high-risk PE based on her PET-C score, her troponin level, and her right heart strain, I mean, she looked pretty ill. And I think if she wasn't 23 years old, she would have had a much more serious presentation. But based on the way she looked and her clinical parameters, of course, we got a CT. We're very worried about a PE. But you can see here she had a very large DVT in her right common femoral vein. And then her CT shows that abnormal RV-LV ratio. And then that interventricular septum is really bowed to the left ventricle, which is completely abnormal. And then you can see she has bulky a central pulmonary thrombus bilaterally in her pulmonary arteries. So we decided to take her to the interventional radiology suite. We did not feel like we should give her systemic thrombolytics. She really was kind of teetering on the edge. She was holding her own, again, because of her age, but we really wanted to do something that would treat her pretty quickly. So we performed a left pulmonary arteriogram. This is called the digital subtraction arteriogram. And you can see there's a very large filling defect in her left lower lobe pulmonary artery. She has a wedge infarct in the left upper lobe and really hypoperfusion to the left lobe of her lung. And then if you look at her PA pressures, they were markedly elevated, 64/26, with normal systolic PA pressure being about 20. So this is very high, especially for somebody who's 23 years old and was a lacrosse player. So we performed suction thrombectomy. In this case, we did use the FlowTriever device. And you can see here, as Dr. Knox already mentioned, is that we're able to aspirate clot that's not only acute, which is typically the more maroon colored clot, but also subacute clot. This is, pretty well organized clot. So just thinking about, doing catheter-directed thrombolysis on there, or even systemic thrombolysis in the patient with a massive PE, I wonder if that would actually be, dissolved or resolved with medical therapy rather than suction thrombectomy. And you could see here the increase in perfusion to her left lung following treatment. And also just looking at her pressures again were in the 60s, and then following treatment really normalized right on the table. Her PA pressures were a systolic of 20. And she also just noticed, it's interesting, she basically said, I feel so much better. I feel like there's nobody sitting on my chest anymore. And her blood pressure improved, heart rate improved, as well as her need for O2 supplementation. And Jefferson wrote a nice story about how she survived a life-threatening PE, which she did. So just moving on to the suction thrombectomy trials for intermediate risk PE. These primarily were published between 2019 and 2023, again after the publication of those European Society of Cardiology guidelines. And these are the FLAIR FLASH registry. Both of these use the FlowTriever device to treat PE, and then the Extract PE and the Interim Strike PE trials use the Indigo aspiration system to treat intermediate risk PE. And just collectively, these prospective single-arm trials, these aren't randomized controlled trials, did show significant reduction in that RV-LV ratio. Immediate on-table improvement in hemodynamics was reported in the FLASH registry. Low incidence of major bleeding and device-related complications. And then some of the more current or recent studies that are being published are really starting to look at more objective clinical outcomes, like the 6-minute walk distance test, instead of just looking at that surrogate marker, which is the RV-LV ratio. In addition, these trials reported a limited need for ICU admission because no thrombolytics are necessary, so that decreases the cost of the hospitalization, and then also a short hospital length of stay because there's no need for extended infusions of thrombolytics. Here's just another case. This is a 58-year-old man, status post recent stroke, who presented with acute shortness of breath and chest pain. And because of his stroke, thrombolytics were contraindicated. So basically, we were obviously deciding between catheter-directed thrombolysis and suction thrombectomy, but based on his history, he was not a candidate to receive TPA. His vital signs were stable. He was tachycardic at 115, and his O2 sat was 88% on room air. His echo showed a heart strain, his troponin level was elevated, his PESI was 1, and then his CT, you can see a really, really bulky bilateral pulmonary artery thrombus. And according to the AHA and ESC guidelines, this patient would be classified as a submassive or intermediate risk, high risk PE patient. So we took the patient to the IR suite, and you could see here that this is a right pulmonary arteriogram, digital subtraction arteriogram, really a very large filling defect in the right distal pulmonary artery with hypoperfusion to the right lung. PA pressures 54/32, performed suction thrombectomy, and here definitely more acute clot than the first case that I showed you was aspirated, but on the table again an improvement in O2 requirements, and his pressures went down to 37/21, and this is just, you can see significant improvement in perfusion to that right lung. So this is my last case presentation. This is an unwelcome visitor, and it's not the patient I'm talking about. This is a 56-year-old man who presented to the emergency room with shortness of breath and chest pain. Hemodynamically, he looked pretty good, although he was tachycardic in the 120s. O2 sat was 91% on room air, but he had a normal troponin level. His S-PET was 1 because of that heart rate. A CTA was performed, which did show bilateral PE, and the patient was started an IV heparin. And based on the ESC guidelines, this patient had an intermediate low risk PE. But we performed a bedside echo. We typically do that on most of our patients. And what we found here was a mobile free-floating thrombus in the right atrium, not attached to any of the intracardiac structures, and this is referred to as a clot in transit. And simply what clot in transit is thrombus waiting to embolize to the pulmonary vasculature. And the prevalence is about 4 to 18% in the literature, but I think that number is going to grow with the, use of echo, bedside echo, for PE response teams. We're using it in the ED, on the floor, in the units. I think we're actually going to diagnose more clot in transit because every clot is pretty much in transit. But it is more common to see clot in transit in patients who have CHF and atrial fibrillation because clot gets trapped in that dilated hyperkinetic heart, and also in patients who have significant pulmonary artery clot burden. If they have high pulmonary artery pressures, this will prevent the clot from migrating to the pulmonary vasculature. And mortality in some reports has been as high as 100% without treatment, and the highest mortality occurs within the first 24 hours. So this is an emergency. So if you get called as a part of a PE response team that a patient has clot in transit, especially in the size that I just showed you, this should not wait until the next morning. But in the literature, if you look at it, prior to the last couple of years, the standard treatment was surgical embolectomy, systemic thrombolysis, or anticoagulation alone. So now with the advent of these new suction thrombectomy devices, we have other options to treat clot in transit. There are 2 types of devices, on and off-circuit suction thrombectomy devices. The on-circuit device it includes the AngioVac. This is actually FDA approved for the treatment of clot in transit, and this requires veno-veno bypass. So of course it needs to be done in the operating room with a perfusionist. And so there are off-circuit devices as well, and the 2 that have achieved FDA approval for clot in transit include the AlphaVac and the FlowTriever device. For off-circuit devices, of course, you don't need veno-veno bypass, and anesthesia could be optional for these procedures. I typically tend to use anesthesia whenever I see clot in transit, just because these patients can decompensate quickly if the clot decides to migrate centrally, just to have additional hands on deck to help manage the patient. But also, I'd like to use intra-procedural echo, TEE or TTE, and this helps me to engage the right heart thrombus with these devices. And there's been case reports and registries and case series that have demonstrated safety and efficacy of these devices. In addition, these devices are equipped with mechanisms to limit blood loss. So not only for clot in transit, but of course for treating PE, it really helps decrease the amount of blood that is needed, that is lost by the patient. But with clot in transit, just be very careful because prepare for the worst. In our institution, it's the cardiac surgeons who primarily place patients on ECMO, so we always notify them, let them know that what we're dealing with. Not so much concern that I'm going to injure the heart, it's more so that if the clot goes centrally, that the patient may need to be placed on ECMO. So we also have the ECMO equipment in the procedure room or right outside the door. And this is just that one case I showed you, and this is the clot that was aspirated from the right atrium. And then this is this patient had a TEE during their procedure, and you can see here's the FlowTriever device, and you can see that there's no longer any clot in the right atrium. And then I just wanted to show you one of those devices that helps decrease blood loss. So this is called the FlowSaver device. And this syringe here is what you're aspirating from either the right heart or the pulmonary vasculature, and this has blood clot as well as free-flowing blood. You inject it into this cylinder, which contains a 40-micron filtration device. The clot gets trapped in there, then there's free-flowing blood here, which you can go ahead and inject it into the sidearm of the venous sheath in the groin or the neck, whichever you're using. And you can see the amount of blood clot you can remove with these devices. And then we went ahead and treated the patient's PE as well. We were a little concerned that maybe a portion of it did go centrally from the right atrium, but he did extremely well. So I just wanted to give a little glimpse into the future. These are the prospective clinical trials and registries that have been published over the last decade. The gray boxes here, as you can see, represent randomized controlled trials, and most of these trials are for intermediate risk PE. And prior to 2024, really, you can see there's a paucity of randomized controlled trials. In fact, the ones that have been published have been very, very small, and again, hard to draw conclusions about. But if you look at 2024, it's pretty impressive. There's 8 randomized controlled trials, and most of these are very large trials that are looking at catheter-directed therapy compared to anticoagulation alone, or comparing different techniques such as catheter-directed thrombolysis versus suction thrombectomy. So I think, going forward in the next few years, we're really going to get a lot of good data with good clinical, outcomes, more objective outcomes, looking at the efficacy and of these devices. So in summary, so the observational prospective studies we have so far have really demonstrated efficacy and safety of these catheter-directed interventions. The benefits of suction thrombectomy, of course, no need for lytic therapy. You're rapidly able to alleviate the patient's clinical symptoms and RV strain. And then you have the ability to remove different age of clot, subacute, acute, chronic. Now, the superiority of suction thrombectomy over catheter-directed thrombolysis is not clear, and and we might have some really good data in the next few months. The Peerless randomized control trial that compared the 2 techniques will be available in August of 2024. So quite excited about that. And then additional randomized controlled trials that are ongoing, evaluating long-term clinical benefit of catheter-directed interventions will really provide us with valuable data to optimize and better understand the management of these PE patients. And just wanted to do a shout out for PE response teams. I mean, again, PEs evolve in real time, and it's really important to have a multidisciplinary approach to expedite and optimize patient care. And I thank you for your attention.
Thank you both so much. That was wonderful. That was some incredible presentations from both of you. We are over the hour, so we're going to go ahead and close, but we invite you to send your questions to the email you'll share right here, the email written over here. We appreciate the invitation from our colleagues at the CVTC Division of Blood Disorders and Public Health Genomics to present today, and thank our colleagues of the National Blood Clot Alliance for hosting the webinar today. You will receive an email asking for your feedback, so please respond with your comments. The webinar will be archived, and the content will be available at CDC's Division of Blood Disorders and Public Health Genomics website, as shown on the slide. Thank you very much for joining us today, and have a great afternoon.